Hello and welcome to Dr. Kathryn Garforth and Dr. Matthew Blackwood speaking about medication and pharmaceuticals as a treatment for ADHD. I think we'll just start out by having Dr. Blackwood reintroduce himself.
Good afternoon, everybody. My name is Matt Blackwood. I'm a family doctor currently residing on Bowen Island. However, I did most of my primary care in Mission, BC, just a little over 41 years. From about 1987 until the present time, I've had an interest in ADHD across the lifespan. During this period of time, I've worked on a child and youth mental health care team with a focus on ADHD, and I've been quite active in the area of education as far as ADHD is concerned. And I had the privilege of being on the board of CADRA for 4 years, finishing a little over a year ago. So ADHD has been kind of like an interest I've had, and watching these kids who are diagnosed with the disorder proceed through the different stages of their lives into adolescence and into adulthood, still with the challenges of having to manage the disorder, and management being both the non-pharmaceutical strategies as well as the pharmacological strategies. So today we're going to be talking about how we can best apply those strategies to various phases throughout the lifespan.
Right. So can you start out by providing with a summary of each of the major medication categories for ADHD and how they differ in their effect?
Sure. Well, we have basically the stimulants and the non-stimulants. The stimulants are divided into two classes, the methylphenidate class and the amphetamine class. There is a preferential response within this class with individuals where a third will have a preferential response to methylphenidate, which is commonly known as Ritalin, Concerta, Bifenton, or Foquest. And another third will have a preferential response to the amphetamine base class, and that is dexedrine, Vyvanse, Adderall in that class. And another third will respond to both classes. And so whatever we prescribe in ADHD from the very beginning, and we always start low and go slow with our medications, we'll have about a 65–70% chance of getting it right out of the gate. If you don't, then you switch class. And then we generally go with the psychostimulants to begin with because they're the ones that have the most efficacy. The effect size of a stimulant is anywhere around between 0.9 and 1.1, and that is actually huge when we treat any condition with medication. For example, the effect size with an antidepressant for a mood or anxiety disorder is around 0.5. So that gives you some perspective as to how effective these medications are. In the non-stimulant class, we have atomoxetine and guanfacine XR, which is intuitive, and the effect size of atomoxetine or Strattera is around 0.5 to 0.6, and guanfacine XR is probably around 0.5 to, let's say, 0.5. So clearly, the psychostimulants are the drugs of choice to begin with. We also have other medications such as bupropion, which is an antidepressant, which has a mild effect size response for ADHD. You might be looking at an effect size of 0.3 to 0.4, but clearly we want to give everybody, providing there's not a contraindication, a chance to have a trial of stimulant therapy. So when the nice thing about the psychostimulants is that they do not bioaccumulate, meaning that once we give the medication for its duration of action, they're formulated to have an effectiveness over, let's say, from anywhere from 4 to 16 hours during the day, the way many of them are formulated. And once they finished working, they basically are cleared from the system, whereas atomoxetine, guanfacine, etc., do bioaccumulate. So the nice thing about a psychostimulant is that if you're having a side effect, they tend to resolve fairly quickly. So in the methylphenidate class, for example, we have medications that can be sprinkled or dissolved or swallowed. For example, with bifenthrin Foquest, we can sprinkle those medications. The other two big drugs in that class are Ritalin and Concerta, and all those medications are released differently in terms of in the first 4 hours, you may get anywhere from 50% to 18% release, depending on the choice of medication that you make. In the amphetamine class, we have Vyvanse that can be chewed, dissolved in water. Dexedrine can be, the Spancil can be sprinkled. So in terms of, a lot of kids can't swallow pills. So we have to look at strategies that will employ dissolving, sprinkling, or chewing. Why don't I just leave it at that? Any further questions regarding?
Lots.
Yeah.
So I guess one is looking at how does the metabolic rate that an individual has affect your method of prescribing them?
It doesn't.
Okay. So how are the stimulant medications absorbed? Does it have to do with an individual's, I guess, with their height, weight, age, or their metabolism? So that you're saying that it's...
Yeah, we used to talk about dosing as per milligrams per kilogram, and that doesn't really apply. You'll find adults who are weighing 200 pounds will respond to, let's say, a very small dose of a psychostimulant, whereas in some children, they will require much higher dosages. So the response is generally unique to the individual. I think what we have to be careful about with some kids, particularly with motility disorders of the bowel, where they have like an irritable bowel syndrome, or an adult, that they move the capsules through the system very, very quickly. The multi-coated layered capsules that we see with bifenthrin and Foquest, if you use medications that suppress acid production, then you can suppress the immediate release component of the medication. So that's something where we have to pay attention to, particularly in adults when they're on acid-reducing medications. The other medication that we are a little concerned about with rapid motility through the bowel is Concerta, which is based on what we call the OROS technology. And if that's moved through too quickly, the medication is not absorbed appropriately. So what you have to do is really, address your treatments to the individual. And always start low and go slow. Even with the big adult, don't be fooled with body weight.
Right. Well, and then I guess that's another important thing to consider is once you've tried like one ADHD medication, you've tried one. There are the different classes, and you need to consider
an
individual's how they respond to it. So, if you're a parent or someone with ADHD and you've tried one medication, realize that it's just one medication, and trying a different medication will have a different result.
Yeah, I think one of the big things you have to be concerned about is the duration of action of these medications. For example, bifenthrin is an excellent drug that can be sprinkled in with small children, where 40% of the medication is released in the first 4 hours. And a lot of children, their greatest impairment is in the first 4 hours, the first half day of school, if you like. And so bifenthrin will address that. Whereas some of the other medications like Concerta, only 22% is released in the first 4 hours, and Foquest, which is the new kid on the block, only 18% is released in the first 4 hours. Ritalin SR, 50% is released in the first 4 hours. So you're constantly playing around with these drugs. And one of the things that you have to worry about is rebounding when these drugs stop working, because rebounding can be a real problem. And so sometimes what you end up having to do is to add another short-acting medication to your longer acting medication to cover a longer period of time during the day, but sometimes to mitigate against rebounding. Sometimes we have to prescribe the longer acting medications twice a day in order to get that duration of action that you look for. Ideally, we would like to have a medication where you use it just once a day and you get that waking period covered. For example, Vyvanse, which is an amphetamine-based medication, duration of action is about 14 hours theoretically, and Foquest 16 hours, which is methylphenidate. But again, you can have these medications only working for 8 to 10 hours in patients. So you really have to listen to your patient and titrate as per impairment and response.
Okay, so I think that one of the questions was, how can we help the kids who metabolize the meds so quickly, even if it's long lasting? And you're saying that doubling up.
Well, yeah, what you end up is increasing the dose, and you might want to just multi-dose during the day. I don't know as much that they're in fact rapid metabolizers, but they might be just poor absorbers of the medication. So they don't metabolize it quickly, but they absorb it poorly. And methylphenidate is more poorly absorbed than the amphetamine-based class. So yeah, it's you just have to sort of play around with it. And again, you start low and go slow.
Right. And then someone was wondering if vitamin C or ascorbic acid has an effect on the absorption of these medications.
I don't think so.
Why is it that the same medications are effective for both inattentive and hyperactive types of ADHD? Both are caused by low dopamine. Why is it that they manifest so differently?
Well, I think as we were talking about yesterday, you have the 3 different types of ADHD. The combined type, which is inattentive, hyperactive, impulsive type. You have just the primary inattentive type and the hyperactive impulsive type. They all respond to a psychostimulant. And yes, what you're doing is you're firing up the prefrontal cortex, which is underactive, and increasing dopamine levels in that area. But there are also other tracts in the brain that you're actually increasing dopamine levels in as well. Particularly in the midbrain and what they call the mesolimbic system, and that has a lot to do with what we call hedonic tone. If you're generally happy, sad, that type of thing, not clinically depressed, but you're more negative than positive, that type of thing. So these medications, it's not just simply the prefrontal cortex. There are other areas of the brain that are impacted by treatment. And but what we do know is that for all types of the disorder, they do respond to psychostimulants, and that efficacy applies over all classes of ADHD, of the effect size of 0.9 to 1.1 type of thing.
Right. So what you're saying is because ADHD has to do with the prefrontal cortex,
yeah,
regardless of presentation,
yeah,
that we have medications that help stimulate that area, it's going to help.
Yeah. Well, what it does is they block the dopamine transport system, the reuptaking system, and so it increases the amount of dopamine in the synapse in the brain. The other thing is that the amphetamine class also will stimulate the release of dopamine as well. So, but then again, noradrenaline is also factored into as a neurotransmitter with ADHD too. And so that's, the most important thing is that you have to, we can sort of understand the neurochemistry, and that's, I think it's very important to do that, but it's important to understand your patient and to really I think what's most important in this whole process, and we talked about it yesterday, is that to have the patient become a student of this, to really understand what you're trying to do. And before I begin treatment with all patients, I hand patients out the CADRA medication list of all the medications and dosage ranges for these medications across the lifespan that we have in Canada today. And so going through that massive list and why we choose what we choose. And if it doesn't work, then the next step down option might be. And so I think going into this, I think another big thing that, as a parent, to medicate your child with psychoactive medication, that is a huge hoop for parents to jump through. And I think you never want to get into a power struggle with prescribing. All that you want to do is to educate and just get them to understand the neurobiological basis to the disorder and what we're trying to do with our medical management. Similarly, if you have an underactive thyroid, what we do is we treat you with thyroid replacement therapy to normalize your function. Similarly, with ADHD, what we're trying to do is normalize neurochemistry in the brain and function. The response to a stimulant is often with first dose. Okay, within the first 2 days, you will notice something, good or bad, but you will notice it. Whereas atomoxetine, the non-stimulant, will take up to 4 to 6 weeks to maximize response to dose and that kind of stuff. So what I do is when I prescribe a stimulant, I usually see the patient every 2 weeks to see what's going on, what the upside and what the downside of treatment is, because these drugs do have side effects. They suppress appetite and they may disrupt sleep. They have non-specific complaints of abdominal pain and headache, et cetera, but they tend to extinguish over time. And if you start low and go slow, you tend to avoid those side effects. But again, I just want to go back to a really big issue in that life today for many individuals with ADHD is very complicated, and you do need to look at those psychosocial supports hugely, and particularly with kids, it's important to address sleep, to get into look at sleep hygiene and the sleep ritual. You don't want a tired, cranky kid who's not getting enough sleep. It's important to look at diet, okay? Making sure that they're not binging out on junk food, making sure they're eating appropriately throughout the day, and they're not skipping meals, because if they don't have any gas in the tank, they're not going to function well. So it's important to address nutrition, which is a really big thing. But a huge thing that we have to address at all ages now is screen time, okay? And particularly during COVID and isolation and that sort of thing. Because for kids to socialize, they're having to socialize with their screens now, right? And one of the biggest problems that we're seeing is with the gaming disorders, internet addiction, et cetera. So I think what's important is that you regulate time on the computer. Probably with COVID, we used to say 2 hours a day was probably a good idea over and above, what you do academically, but probably limiting it to no more than 3 hours a day. And for a lot of kids, that's really can be really challenging. And the more difficulties a kid is having, or an adult, the more time they spend on the computer. The longest I've seen has been up to 14 hours a day. And so that was extremely challenging. So you start early in putting in those controls because it'll be a lot easier to do when they're younger rather than when they're older. So I just want to say one last thing, okay, about social rhythms and the non-pharmaceutical approaches to management, and that is exercise. Exercise is key for a number of reasons. One, it's just good for you. Two, but exercise for mild to moderate depression is equal to taking antidepressant in terms of effect size. So it's important, particularly for wherever you are in the lifespan, that you are getting out and you're active.
Definitely. So you touched on a couple of our other questions, so I think I'm going to bump them up in the order. Okay. One was, with medications that have an appetite suppressing effect, how important it is to make sure that the child eats well during the day, even though they don't feel hungry, because surely enough, the energy from the foods is needed for their brain to function well, and especially as they may struggle with learning.
Yeah, I think number one is that they for sure have a good breakfast, right? What you'll often find is that for example, the meds like bifenthrin, dexedrine, whatever, they work. The Spansil for dexedrine works for about 8 hours, and bifenthrin 10 often is shorter. So they wear off by dinner time. Sometimes you just have to accept the fact that they're going to just graze and be picky during the rest of the day. I often talk about the Boost Gummy Bear Popsicle, which works really, really well. And do you know what Boost is?
Like the meal supplement, like Ensure?
Yeah, like that. And it comes in chocolate, strawberry, vanilla. And you get frozen berries like blueberries, raspberries, and the juice sticks used to make popsicles for the kids when they're younger. What you can do is put a gummy bear on the pointy part of that plastic thing for the popsicle, pour in the Boost, and cut the sweetness by putting in some berries and making Boost gummy bear blueberry popsicles. And the kids get a lot of nutrition from that, and so I haven't had a kid that says I don't like that, and so it's one of the strategies, and but sometimes kids will lose a lot of weight, right? And whatever you do, it's hard when you're a parent to see your kid lose all this weight. So a lot of parents, what they'll choose to do is to treat on school days only. They will have drug holidays at Christmas, Easter, and during the summer to allow growth catch up. We ideally prefer kids to be on their medications all the time, but some parents will just say, I'm not going to do it, because it's clear that they're losing weight. And so if it's really profound with on a stimulant, you may go to another class of stimulant, or you might have to go to atomoxetine, but they can still lose weight and have appetite suppression with the atomoxetine as well. So again, you just have to tailor your treatments to the individual, and just work through it. It can be really complicated with some kids.
Definitely. So someone was asking, why do physicians not check for nutritional deficiencies before recommending the pharmacological solutions or medication?
Well, the ADHD is not a nutritionally based disorder, okay, number one. And so the nutritional problems that we have today are with childhood obesity, which in fact it's taking too many calories in generally. And multivites don't really work for ADHD. So there's no point in prescribing large amounts of multivitamins, et cetera, et cetera. I think a well-balanced meal plan is basically all you need. But you're dealing with a neurobiological disorder, which requires strategies to target that disorder. There are no dietary strategies that really do that. And so the other question is the omega-3 fatty acids, okay? And the evidence is really sparse regarding that. And so generally, I haven't been in the habit of prescribing the omega-3s just because I haven't been impressed with the science at all. And so, but that's my bias, and some people do. But I haven't seen anybody sustain compliance with the omega-3s. I just haven't seen it. They start, but they usually realize it's not that good.
Right. So someone was wondering, why is it that the chemical imbalance in individuals with ADHD cannot be measured or proven?
Well, the problem is that you can do functional MRIs, you can do PET scans, those sorts of things. So you can, as a metric with imaging, it's there. Okay, we see these abnormalities, but we don't have a blood test for ADHD, and so the diagnosis is really clinical. And apart, and obviously it sounds a little facetious, but we don't do brain biopsies. I guess a brain biopsy would show you that, but we obviously don't do that sort of thing. No, there are no markers, and there are no specific tests that we do. And the functional MRIs, PET scans, they're investigational. Those are things that we don't order at all, nor do we order an EEG tracing, a brain electroencephalogram, because there's no EEG markers for ADHD. So there's no point in doing it. Yeah.
Right. Someone was wondering, if you give an individual with comorbid conditions medications for the ADHD, is it possible that the characteristics of the co-occurring condition become more prominent?
That's a good question about, let's talk about comorbidity and ADHD, okay? Because as the child moves into adolescence and into adulthood, comorbidity becomes such a big part of the presentation. So it's rare that you see ADHD all of its own in an adult or an adolescent. There's usually something else going on: mood, anxiety, oppositional defiant disorder, conduct disorder, substance use disorder. You may see a tic disorder. You may see also a learning disability. So the one rule we have with ADHD, with treating a comorbid disorder and ADHD, is that you treat the most impairing diagnosis first, and you focus on the most impairing diagnosis. So when we start to look at another way of looking at ADHD, and I'll come back to the impairing diagnosis and talk about a few of them, but to look at comorbidity as much as the way that you look at a pneumonia and a fever, okay? So if you present with a pneumonia, I don't treat the fever. I treat your pneumonia with an antibiotic. With ADHD, the pneumonia is in fact a depression, for example, and the ADHD is in fact a fever. So, and often when you treat the pneumonia or the depression, the PDF file that we see with ADHD, many of the impairments get a lot better. At the same time, often we've seen where we've been treating patients for depression that just simply don't get better. They get a response, and then when you add the psychostimulant, you take it to the next level, and it can be dramatic with a number of patients. So the important thing is that you treat the most impairing condition first. Substance use disorder and ADHD, really a hot topic. Many individuals presenting with alcohol abuse disorder and substance use disorder have underlying ADHD. And so can you manage them concurrently? And that's a hot topic. My approach has been that the problem is addiction first and foremost, and that you treat the addiction and you have a period of abstinence. And then once the ADHD becomes more, if it's still there, then we address treating the ADHD, but we do it carefully and with what we call pharmacovigilance. So that's a challenging issue. Now, the other problem is when you treat with, let's say, a psychostimulant, okay? And can the comorbid condition get worse? Absolutely. And that's with anxiety disorder. You can make an anxiety disorder worse with a psychostimulant. So you have to be very careful with that. Another issue that you have to worry about in what is comorbid with the disorder is somebody with bipolar disorder. And if you never treat anybody with a psychostimulant who is manic or hypomanic. I mean, you just don't do that. And those patients need to be really assessed by psychiatrists, and those patients may do better with a non-stimulant, particularly the substance use disorder patient, that often we go to atomoxetine, even though it's not as efficacious as a psychostimulant. So does that answer your question?
Yeah, well, I think what they're saying is that the ADHD was the thing that was causing the most of the problems, right?
Yeah.
But those symptoms have been controlled and they're able to focus more. it's
Yep.
causing them to have more heightened symptoms of the underlying conditions as
Yeah.
well.
Well, yeah. I've seen that. What is interesting, and I recall I had one patient who, in all adults in late teens, I always screened for depression and anxiety. And for depression, we use the PHQ-9, and for anxiety, we use the GAD-7. And but when you talk to them, yes, they seem anxious, but they don't seem to have an anxiety disorder. They seem to be down and frustrated with the impairments that they have with their ADHD. But in order to make the diagnosis of depression, you have to have what we call anhedonia, lack of obtaining any pleasure in your life, and sadness. And when you can't really nail anhedonia and sadness, then what I've done is I've focused on treating the ADHD, and I've seen those PHQ-9 scores and GAD-7 scores normalize with psychostimulant treatment. But again, it's all knowing your patient and looking at that impairing narrative that they come with. I think the thing that will really is important to really take from this is that you don't treat the toolkit. You don't treat the questionnaire, you treat the patient. The questionnaire helps you in your assessment. It becomes a metric for treatment, but you treat the patient, you don't treat the questionnaire.
Yeah. Someone was asking, why does medication clear their head but still leave them feeling jittery, even on a non-stimulant medication?
Mm-hmm.
So I guess it's the thought, but still needing the fidget.
So the fidgetiness maybe still be a form of the ADHD, which is unresolved, okay, with treatment. It's one of the problems that you have if you look at when you treat with, let's say, a psychostimulant, there's a sweet zone, there's under treatment, the sweet zone, and then over treatment. So if you see somebody jittery, agitated, and whatever, you've gone into the over treatment zone, and so you have to back off. So again, it's sitting back and talking to the patient. Again, that if you've got an anxiety disorder, that jitteriness or fidgetiness may be an expression of anxiety, and you've actually kindled the anxiety by using a psychostimulant. So again, you have to go back and talk to your patient and find out what's going on.
Right. Someone was asking why performance drugs like stimulants are being given to children when their brains have not finished developing.
Well, your brain doesn't finish developing until about age 25, right? And if you have an ADHD brain, it's going to lag by about 2 to 3 years. There's some evidence to show that taking a stimulant works in a positive way in terms of brain development. You're talking about those things, and it does not impair brain development. Okay, that's important. Okay, you look at the upside of treatment, okay, versus the downside of treatment. Okay, the downside are a few side effects. The upside is absolutely huge in terms of success in school, socially, and also in the workplace. There's another thing that you have to talk about here, and that is the downside of no treatment. Mm-hmm. There's no upside of no treatment. Okay, what is the upside? You don't get side effects. Okay, yeah, okay, that's a bit of a blip. What's the downside of no treatment? The downside is the fact that there's about a 40% chance you're going to develop a substance use or alcohol use disorder by the age of 15. There's a good chance that 30% of the individuals will not finish school or experience failure. You start to look at teenage pregnancy. You start to look at over 50% of individuals with the disorder, their marriages will fail. Frequent job changes, goes on and on and on. So there is a real downside to not treating. And the other thing that we have to be really concerned about is this mortality study that the Danes did in 2015, looking at ADHD and comorbidity, where premature death goes up by a factor of 8 if you have ADHD, oppositional defiant disorder, and a substance use disorder. Bad news. So we have to talk about if you don't treat, then you have to accept the fact that you are going to end up with a really tumultuous various stages as you move through the lifespan.
Definitely. So what are some good resources for the executive functioning supports that are needed to be used with medication?
Well, I think the really good support is CADAC, C-A-D-D-A-C, and you can go to cadac.ca. They're outstanding. CADRA is designed mostly for healthcare professionals, and they have the 4th edition of basically best practices in terms of managing ADHD, widely accepted throughout the world. They've put out a laminate called Psychosocial Supports, outstanding. And also within this manual, there's a lot of great ideas in terms of, for example, transition to higher levels of learning, how you can help advocate for your patient, for accommodations, that kind of stuff, how you can network with your patient to have a continuity of care wherever they're going in the country, that type of thing. So CADRA has a huge voice in the management of the disorder and educating both professionals and non-professionals across the country.
Definitely. Now we have a whole bunch of questions just specifically to stimulants. And a lot of them have to do with whether taking them with something else, opinions and thoughts on that. So one of them is the combination of coffee and stimulants. Is it counterproductive? Does it increase the effect of the stimulant?
Well, it's, we don't usually have people take caffeine tablets or, or Red Bull or anything like that, because what you do with caffeine is that you increase anxiety, right? And anxiety will then, increase your symptoms that we have with ADHD, and it can increase the PDF file if you like. So you've got to just be really, really careful. Yeah.
Right. What about alcohol and stimulants?
Generally, what happens is that it's what alcohol does, obviously, is it blunts cognition, okay, and it blunts executive function. So it's taking 1 step forward and 2 steps back. So wouldn't recommend that you take your stimulant in the morning and have a couple of beer at lunchtime. Not a good idea. In fact, it's sedating, if you like. So no, not good to combine. However, at the end of the day, if you want a glass of wine with ADHD and you've been on a stimulant, that's not a bad thing. You can still do that.
What about when it comes to breastfeeding and pregnancy when you use stimulants as a way to treat your ADHD?
Yeah, I think the evidence is you got to be careful. I know in the first trimester, I think it's just generally a good idea not to take any medication. I know that in perinatal health that many of us just don't really feel totally comfortable treating throughout pregnancy. As far as lactation is concerned, I think that you just have to observe what's happening to baby, and if baby is getting stimulated and they go off their food and they're not sleeping, then you really shouldn't be taking it. So yeah, it's a big problem. I haven't prescribed in pregnancy in all my experience in primary care.
Right. And you talked a little bit about medication breaks. Do you want to go a little bit more into detail about them?
Yeah, well,
and
we
why
recommend that they don't
them?
occur. We recommend that they don't occur, that once you start treatment, you should treat every day of the week, because you take your ADHD brain to school, the playground, family, workplace, that kind of stuff. Uh, but this is a real world, and a lot of parents, it's a huge ethical thing as a parent to treat your kid with a psychotropic drug, and a lot of parents just feel better that they are able to manage the ADHD in the summertime when the pressures are not as bad, and kids want to sleep in. And often what parents will do in the summertime is that they will say, okay, on Wednesday we've got something going on here. We're going to go out and be with family or friends, and I really you have to behave. They will take their psychostimulant on the Wednesday, but they may not take it for the rest of the time. And then you've got those families where the kids are just losing a lot of weight, right? And so they will just stop taking the medication and then only resume it when school starts. So, but ideally, we like kids to take the medication, individuals with the disorder, every day. But so I think taking it some of the days is better than none of the days. And I think, again, we have to look at other strategies to maximize function, because that's what it's all about with ADHD, is function and impairment. And so just really, again, focusing on the scaffolding with psychosocial support is really, really important, okay? Because if you ignore that, then whatever you prescribe is going to fail over time.
Right. How about the changing needs of the medication as the individual ages and matures?
Yeah, two things. Yes, you will sometimes have to increase dose as body mass increases. You may find that effectiveness you may find that the other class may be more effective as you move from, let's say, from elementary into secondary, whereas you may find that the child has done well with methylphenidate, not doing as well in high school, and that's a time that you may want to say, look, I think I'll try Vyvanse in that situation, and you find that, wow, they've done extremely well with the Vyvanse. So again, you just don't know until you try. And so the response is unique to the individual. And so you just as I said, when I go back to starting treatment, everybody gets the handout of the CADRA overview of all the medications prescribed throughout the lifespan and dosage ranges, and say, look, these are the fallback strategies. So we might have to go there.
Right. And what about for adults? I know of adults that, they have ADHD, they've been put on medication and feel that it's amazing, but then people are saying, oh, well, aren't you going to start going off of it now?
Yeah, not a good idea. It's not a good idea at all. And so one of the problems with the adults, it's really interesting. I had just a conversation this week somebody we've started to treat, and in her 50s, and so what you have to deal with is the sense of loss, of not being productive, of not having the diagnosis made earlier, looking at why you haven't been able to hold some jobs down, why, if you were not such a chronic underachiever, just think what you could have done, all the what ifs, but we have to get back and focus on the what is. What the what is that was then and this is now, and so we can move forward, and you provide individuals with a sense of hope. But once you start, most people, once they start, they don't want to stop, just because they can see the difference, right? So.
Right. And do you have like a response that you give for the patient to give to others? And like, well, you don't need it anymore. You're obviously fine. But it's kind of like, well, you're fine because you're on the medication.
Yeah. Well, the other thing is it's interesting. Yeah, let's go back into childhood, adolescence, and adulthood, because we know that, let's say, 8% of kids have ADHD, 6% of teens, and 4% of adults. So what happens is you see a natural remission And that remission really is an improvement of function and then an extinguishing of impairments. They still may have some symptoms which can be managed, okay, and that's who they are. They may still have a PDF file, but it's not an impairing dysfunctional PDF file. And so do they have a disorder? Well, it's not impairing and causing dysfunction. They don't have a disorder. They don't have a disease. It's only when you have dysfunction and impairment that you have the disorder. So what do you do with somebody who's in grade 5? They've been on treatment. They're going into grade 6. And maybe they're in that remission phase. What do you do? Well, the recommendation is that the first week of October, you have a drug holiday. So you'll have the child going back to school for the month of September. And you always tell the teacher, okay, that we're going to have this week not on medication, okay? So we want your feedback, and we have the SNAP 426 that we talked about yesterday. We use as a metric for ADHD and oppositional defiant disorder, and use that as your metric to see what changes are there. And the teacher will know within day 1 or day 2 that the child still needs to be medicated. And you can do that throughout various stages of development, is to see what it's like in the first week of October. And it's not like, these are not subtle changes, right? So often parents will say, or teachers will say, I know Johnny didn't get his medication this morning. Or the parent will be phoned up at recess and say, did you give Johnny his bifenton? Oh, I forgot. Well, they know, they can tell. This is not subtle, this disorder. So yeah, so I think it's important to always question the need for medication as you move through the lifespan, and just yeah, monitor. That's important.
Right. And for our listeners in Australia, October is the second month of school. So for you, it would be going back, I think
February.
it's Jan. Yeah, so it would be February.
Be February. Yeah, I lived down there for a couple of years, so yeah.
Great. Now, one of the questions that we had yesterday and didn't get a chance to get to is wondering whether a child with ADHD comorbid with ODD, is that a result of bad parenting? And, you know, what can be done?
Definitely not. Okay. And I think it's just the way the kid is wired, and the ADHD will drive the ODD. About 40% of kids with ADHD will have an oppositional defiant disorder. And what we find is that when we treat the ADHD, we see an extinguishing of the symptoms associated with ODD. We also talked about sort of ODD, Uber ODD, and disruptive mood dysregulation disorder, DMDD. And that is, those kids are really challenging, and those kids need to be medicated. Okay, and those kids often will do well with combination therapy, with Intuitive XR or guanfacine XR, and that can be dramatic. And I've had kids who can't go to school unless they're on combination treatment. The other thing that we used to see is a number of those kids in the past were treated with the atypical antipsychotics, things like risperidol, quetiapine, that sort of thing. And we prefer not to use those drugs, but sometimes, you know, these kids just need them. And because the other thing that with DMDD, they talk about juvenile bipolar, which is still all up in the air in terms of as being a genuine diagnosis in the pediatric population. But what you have before you is a child who can't cope, is so cortically activated that you have to look at other forms of treatment to actually make them functional and get back to school.
Right. Yeah. So it's really important to know the individual, their needs, and you're treating the most pervasive thing. But as you were saying, with the ADHD, ODD comorbid condition, treating the ADHD, even though the ODD may be the bigger problem, might help lessen the ODD.
Yeah, there's no specific medication for ODD, except that when you treat the ADHD, you'll see a quieting down of the ODD symptoms. So with the SNAP 426, questions 19 through 26 are oppositional defiant disorder, and 4 to 8 is oppositional defiant disorder. So you could have an impact. You can see the ODD be extinguished completely, or you can have it be modified significantly, such that these kids are quite manageable. It's just that when you go beyond the ODD, particularly the last two questions with the hyperirritability, anger management, that kind of stuff, then you're starting to get into more complicated disruptive mood dysregulation disorder, that kind of stuff that that's when you really want to, have a child psychiatrist, pediatrician on board as well. It's, I think as healthcare professionals, we like to really be involved in team-based collaborative care. And that's where I found working on a child needs mental health care team is hugely valuable to have all that input in management.
Right. Now, as a family physician, I'm sure you've heard all the myths and stigmas and objections that parents have. Do you want to just talk us through some of those?
Well, I think the thing that only seems to be happening with boys, it's not true. That's a stage that's going to get better, not true. That you treat your kids with stimulants, you're going to turn them into drug addicts, not true. You're going to prevent that. It's just the opposite. If you treat with stimulants, your kid's going to turn into a zombie. Okay, not true. If you overtreat, you will cognitively blunt, and you shouldn't. We start low and go slow, and we stop our titration when we get a response. Rarely do I can't even recall the last kid I saw was like quote unquote the zombie. It just doesn't seem to happen, just because we're so careful and so measured with our management. The fact that ADHD is going to get better, it doesn't. Half of children who have the disorder will go on to have the disorder into adulthood, and they need ongoing management. So can you think of any other myths?
That they're drugging their child and it's not their child.
That's one of the big, that's where they're being victimized, being judged by not only themselves, let's say, but also members of their extended family and social circle, which is really too bad, because I think once you see parents who sort of cross that line where they become a student of the disorder and not a victim of it, not feeling that they can ignore that judgmental, outside judgmental sort of feedback they're getting, and understand what they're doing is good for their child, and this will lead to success. Because what is the alternative? Not to treat and then accept all that downside that we've talked about. So you're not drugging your child, because what you're doing is you're making your child more functional. So I think that we have to sort of look at words are important, and I think we have to choose our words carefully. And what we're doing is medicating. And so similarly, if your child was diabetic or hypothyroid or something else, we do treat appropriately with replacement treatment. And so it's the same thing for ADHD. We're just this replacement therapy for dopamine and norepinephrine in the brain. And so it's you're not drugging the kid, okay? I think we're drugging our kids more with calories than we are with anything else right now, and drugging them more with screen time. Yeah. Much more dangerous than treating with an ADHD drug. And I think the other big thing is the notion that, well, it leads to addiction. Not so. It's just the opposite.
Yeah.
Yeah.
And then the other one, using ADHD as a label or a cop-out.
Yeah. It should not be used as an excuse, but it can be used as an explanation. Okay. And I think that individuals who are requesting special accommodation academically and also in the workplace, um, they're trying to be successful. They're trying to achieve. They're not asking, and they're not saying, I don't want to do this. They say, I want to do it and I want to do it well. Can you help me do it at a level, at a standard that I'd like to do it at? And so so what they're offering is an explanation as to how they're functioning. They're not asking to be excused. Okay. And I don't see anybody when I've written accommodations for individuals for the disorder, uh, nobody has said I can't do this. It's not to say I shouldn't be doing this. And so I think that's really an important thing. It's not the flavor of the day. Okay, it's not an excuse for bad behavior. But I think we can use it as, again, an explanation as to why people are struggling. And so when we understand it as an explanation, we can then do something about it, and also move away from this judgmental some organizations and individuals have. And I think as people become more educated, then they become more accepting, and they become champions for these individuals. Yeah.
Yeah. Well, the thing is, ADHD is not a label. It's a diagnosis. It's a
Right.
neurobiological condition
Yeah.
that is brain-based,
Yes.
right? And
Yep.
it's due to an impairment in function, and it's not caused by the bad parenting or caused by bad parenting.
No.
Like, there's so many things that we need to dispel, these
Yep.
myths. That's why we're doing this during the
Yep.
ADHD Awareness Month, right? To help people
Yep.
understand that it is a real medical condition. There are real brain differences in the difference between an individual with ADHD and an individual without ADHD.
Yeah, yeah. It's the whole issue of neurodiversity, right? And that's, yeah, it's like even with on the spectrum, it's all about neurodiversity. And there's a place for all individuals with neurodiversity. It's just that we have to accommodate them and have them function optimally. So, and the nice thing about ADHD is how much we know about it. And I don't think there's anything more that I treat in medicine which is so dramatic in terms of a response, in terms of function. Yeah, you can treat an asthmatic attack, you can treat a high blood sugar or a low blood sugar. Yeah, the patient feels better, but in terms of being really grateful for what you've done, it's when you treat ADHD, when it's really had a significant impact on their relationships, what they do during the day, et cetera, and self-esteem, hugely bolstering for self-esteem to be effectively managed.
Of course.
Yeah.
What advice would you give to a parent that thinks their child has ADHD?
Oh, I think really important to go and see your family doctor. Okay, don't go to a walk-in clinic. And if your family doctor does not know much about it, then ask to be referred to a pediatrician. Most pediatricians today are very well informed, but you are your advocate for your child. You are the case manager for your child. And sadly, in primary care, there are physicians who still have a problem with this diagnosis. If they were being examined in medical school, they wouldn't pass with some of their attitudes. And so I think that if you really feel that there's something wrong and you go through the screening tools will rule it in. It doesn't necessarily rule it out. And you just really need to go and talk to somebody about what is going on in their child's life. There may be other things, but at least ask the right questions and have the proper assessment. And I've seen pediatricians who don't even apply the various screening tools and will say, no, I don't think the child's got ADHD, which is wrong. So, I think you just have to be persistent. That's the message. Yeah.
Definitely. What about for an adult that thinks that they have ADHD? What would you suggest for them?
Again, go talk to the family doctor, do the adult self-reporting rating scale. Not only would I do that, I would do rating scales for anxiety disorder, mood disorders, that kind of stuff. Again, with ADHD, we talked about, am I the ADHD doc? Am I quacking like a doc? Do I walk like a doc, and do I look like a doc? And our diagnostic criteria are that you have to quack like a duck and walk like a duck. Quack like a duck, that impairing narrative, and what we see with the rating scales. Walking like a duck is that you've actually walked with your disorder from throughout childhood, adolescence, and into adulthood. The cutoff that we have with the DSM-5 is at age 12. It was moved from age 7, but it's now age 12 to capture the primary inattentive types. But we know that ADHD is highly heritable, anywhere between 60 to 90%. So when you have somebody in the family with ADHD, particularly if you have a child with the disorder, there's about a 50% chance that you probably have it. Okay, so it's important to be screened and assessed and managed. And so I think what's important is you have to do the due clinical diligence that you need to rule it in, as well as rule it out, as well as look at what else is going on. And I see with the adults that I've managed over the years, there's only been just a few, not very many, who have been drug seeking. They are really genuinely concerned about, the impact the disorder is having in their life. And so I think they have to be taken seriously.
Definitely. Well, thank you so much for joining me, Dr. Blackwood. I've really enjoyed our conversations.